In the next 1 hour, I'm going to go to the newborn assessment. And if time allows, I will touch the newborn resuscitation as well. Can you all see my slides? You can.
Yeah, we can. Thank you, Doctor.
All right. So we have in the UK, we have established newborn assessment system. This is called NIPE system, that is newborn and infant physical examination system. So here we have 2 main checkups for the newborns within 72 hours of life before leaving the hospital, or it is by a qualified community midwife. And then the second checkup at 6 to 8 weeks of age with the GP. So this can be vary from country to country, but universally it is must to do a proper newborn examination, head-to-toe examination within 72 of age. So it is important to do the newborn examination. Do you know why it is important? Is anybody want to answer why we need newborn assessment?
Hello, can I answer?
Yes, yeah.
Okay. First, thank you for arranging this entire course and for this lecture. And secondly, I think the assessment is very important to track down any abnormality or genetic disease that might develop later on, and to track the progress of the patient, or to notice any failure of thriving, etc.
Yes, brilliant. So let's see why we need newborn examination. As you told that there are some life-threatening condition which come from birth, congenital problems which need early intervention to prevent mortality and morbidity. If we identify them early, we can prevent the death, sometimes the morbidity as well. So there can be some structural defects in any organ, and identifying this early can improve the outcome of the babies and sometimes the quality of life. And there can be some life-limiting condition which we need to consider palliative care, and this identifying early of these life-limiting conditions important for the family to have good palliative care. Right. So those there are some congenital problems like syndromes, structural defects, and some metabolic disorders like inborn errors of metabolism or hypoglycemia. Hormone and the hormone deficiencies like hypothyroidism, hyperthyroidism, and congenital adrenal hyperplasia and congenital infection. So I know that you can see the slides, but do you know about the congenital infection? Have you heard about any congenital infections? Anyone want to answer?
Can I?
Yes, please.
So the most important, without looking also at the slide, the most important and famous in medicine while we're studying pediatrics is torch infection. Yeah. So
yeah,
and yeah, it is just a term that abbreviates many congenital microorganisms.
Yeah, especially for the congenital infection, we have this mnemonic called TORCH. So it indicates TO is for toxoplasmosis, and R for rubella, and C for cytomegalovirus. H is for 3 organisms like HIV, HSV, and hepatitis B infection, and S is for syphilis, right? So these are the kind of common and important infection that can cause problem in the in utero. So I think you are aware about the congenital infection. What is mean by the congenital infection? That means the fetus get the infection from the transplacental route, right? So if they get the infection during the early pregnancy period, they can have, especially as you know from your embryology, organogenesis happen in the first trimester. So if something happen in the first trimester, it can cause structural problem. So toxoplasma or rubella or CMV infection, if it is happen in the early trimester, it can cause some structural problem in the organ. Especially, it can affect the brain. So, if it is happen in the late pregnancy, it is mainly the infection, but it doesn't cause organ problem. So, especially HIV, HSV, and hepatitis B, it can cause the infection in the baby, but they don't cause some structural problem. So it is important to screen or identify these problems to treat early, because we can prevent or further damage, or we can prevent the infection by treating. And then these are the congenital problem, which the syndrome, structural defects, and the metabolic diseases, those everything's are congenital problem. And then in the assessment, you have to, sometimes we have to identify birth trauma. That is also important, because if it is due to, sometimes we have to take the babies out from the assisted forceps delivery or from the vacuum delivery. This can cause some birth trauma, which is life-threatening, or sometimes structural, like morbidity, which can lead to morbidity, like Erb's palsy, facial nerve palsy. Sometimes it can be a hemorrhage or some hematomas, the fractures. These hemorrhages can be even life-threatening. And apart from the congenital infection, it can be some early onset or late onset infection that acquired during the process of birth or from the postnatal period. So sometimes it is important to identify this infection, which can lead to even death. And then the maternal diseases also important, because some of the maternal diseases can affect the baby. Even they can cause structural problem, especially gestational diabetes mellitus. I will come into the gestational diabetes mellitus later, because it is important condition that can affect the baby. And hypertension, it can cause placental insufficiency, and then the fetal growth restriction. Maternal hypothyroidism, both can cause hormone imbalance in the baby as well. And connective tissue disorders, SLE especially, and the condition which has this anti-Ro-anti-La antibodies. You may have heard about this anti-Lo antibodies from your medicine appointment. So it can cause congenital rhythm abnormalities, especially congenital cardiac block. And some medication also can cause, it has a teratogenic effect. And the next category is the maternal substance abuse, especially alcohol. Using of alcohol during the pregnancy can cause fetal alcohol syndrome of the baby, which can cause significant behavioral problems in the later of the life. And then the neonatal abstinence syndrome, that is withdrawing of the drugs from the mother, especially with the opioids users. Baby can have withdrawal symptoms, including seizures. And then cocaine use during the pregnancy can cause cerebral ischemia. And there are, the next category is the benign condition. Sometimes we have to identify these benign conditions just to reassure parents. Then, okay, it's not moving. Can you see my slides moving?
No.
No. Okay. So we have some screening system. This can be vary from country to country, but UK and I think everywhere we do antenatal scans. Initial scan is the dating scan, just to make sure that date is correct. And then we do anomaly scan at the 18 to 22 weeks of gestation to identify some organ structural abnormalities, but this is not always reliable. There can be some inter-operator or intra-operator variation. It depends on the operator. So sometimes we can miss this anomaly scan if you booked in the later pregnancy. So always we have to actively look for anomalies, even if the anomaly scan says that these are normal. And then antenatally, we offer triple test for trisomies, identify the trisomy, especially these common trisomies, trisomy 21, 13, and 18, only for the high-risk pregnancies. So we have this triple test called alpha-fetoprotein. We check alpha-fetoprotein, human chorionic gonadotropin, and estradiol to identify the high-risk pregnancies. And if you suspect high chance of having trisomies, amniocentesis and or a chorionic villus sampling can be offered to the parents, but it's depend on the parent wishes because it carries a small risk of miscarriage, but it is the genetic it is for the confirmation test. And then if it is a life limiting condition like trisomy 13 or 18, then they can go for termination of pregnancy. But some countries, it is not legalized yet. Then the HIV, hepatitis B testing for all women, because it is important to identify these serious infection to prevent it going to the baby. So high-risk ethnicities, here they offer hemoglobinopathy screening testing like thalassemia and sickle cell. And then for all ladies, all pregnant ladies, glucose tolerance test is must to diagnose the gestational diabetes. Not only antenatal scans, we have this postnatal screening system. It depends on it again varies from countries to countries. I think high resources countries have this facility to identify the hundreds of genetic conditions, especially metabolic conditions, by doing this blood spot test, which we call Guthrie test. It's just a heel prick sample we take on day 5 of life to identify rare but serious complications like these metabolic disorders, spike phenylketonuria. You don't have to remember these diseases if you're not doing the pediatrics, but there are some metabolic conditions which is serious and even can cause death. And the hormonal and endocrine disorders like hypothyroidism, it is important to identify congenital hypothyroidism early because it can be treated. And then the congenital adrenal hyperplasia, that is also the same. And then the blood disorders like sickle cell disease and other condition like cystic fibrosis. So over 200 rare condition can be diagnosed, and this, as I told, this can be varied according to the countries. In UK, they offer 9 standard diseases at the moment. And before doing your neonatal assessment, history is important. So you have to ask from the parents regarding any antenatal concerns and maternal diseases and the medication which can affect the baby. And mode of delivery is important, especially whether it is assisted delivery or a breech presentation. So does anyone knows why the presentation is important? What is the risk of having breech presentation?
It's because for the hemorrhage in the brain.
Yeah, I mean, breech, it is partially right. It can cause some difficult delivery and then it can cause some problem birth trauma. But the important thing is if you have a breech presentation, it can cause developmental problem in the hips because of the position in utero. If your baby keeping the legs flex position for a long period, it can affect the development of the hip. So if your baby born in the breech presentation, even if hip examination is normal, we offer screening scanning test at 6 weeks, 8 to 6 weeks of age to to exclude the hip development problem, which is called congenital hip
I'm sorry, I misheard or misinterpreted the question. I thought that you asked about the mode of delivery,
Okay.
the forceps.
Yeah. Then in that case, you are correct. Yeah, especially forceps and vacuum extraction can cause extracranial or even intracranial bleeding, and sometimes even skull fractures. Yes. Sorry if I
I'm sorry, I
talked to both
misunderstood.
things.
It's
Yeah.
okay. Thank you.
Yeah, then we can ask from parents regarding any birth complications, that is like hypoxic condition. That is also important whether baby cried soon after birth or whether the baby took time to cry. So it indicates a hypoxic event. And then it is important to ask the feeding and activity, especially to rule out some infection. When the problem is with the newborn, they can't tell you what's going on with them. So we have to actively look for things, and especially if they are not feeding well or they are not waking up and less activity, that indicates some problem with them. It can be infection, it can be some metabolic condition. So we have to always look for it and ask from parents, because the baby can't tell us. And then the urine output and bowel opening, also it's important to ask. They should pass urine and stool within first 48 hours of life. If there is no pass of urine or stool within the first 48 hours, we have to suspect of any obstruction. Have you heard about any condition of obstruction to the stool, like gut problems? What are the things you have to check if your baby is not passing stool within first 48 hours? Anyone knows?
Hirschsprung and maybe esophageal atresia.
Yes. Yeah, sometimes, yeah, if it is a total esophageal atresia without fistula, then maybe they are not going to pass meconium. But important thing is the
Hirschsprung.
Hirschsprung as well, imperforate anus. Always you have to check the anus patency, right? You can miss that. There can be sometimes fistula, rectovaginal or fistulas, and if you didn't check it, if you haven't checked it, you can't identify the imperforate anus. So you have to actively look for it, the anal patency. So other condition like bowel obstruction also important, like the atresias. There can be rare jejunal atresias, ileal atresias like that. So it is important to pass stool within 48 hours. And the urine, especially when it comes to boys, if they can't pass the urine, you have to think about the posterior urethral valve. Okay. And then family history also important, because some of the congenital cardiac problems, hearing problems, congenital cataract or congenital hip dysplasias can run in the families. So you have to ask those questions, and if there are any significant family history, we have to screen the baby for those conditions. Okay. I wanted to talk about a little bit of the infant of diabetic mother, because it is important and it is a common condition in the pregnancy. Have you seen any babies? Have you had an experience of these babies? Have you done any neonatal examination in babies? Anyone want to answer?
Yes, I did.
Yeah. Okay, good. So have you seen the complication of the GDM? What are the
GDN.
problems? Yeah, gestational diabetes mellitus is the GDM. So
I saw like a big baby. Like they usually have uh increased weight, and they have like to be delivered sometimes in CS. But unfortunately, I haven't met many cases in with mothers with diabetes. So
Yeah, because nowadays, actually, because we actively identify the gestational diabetes mellitus and we treat them, because of that, it's under control. So if it is poorly controlled, then the complications are high. But if it is under control and better control, then these complications are less. That's why these days you can't see these complications. But if it is under control, they are high risk of having structural defects and also some metabolic defects.
Yeah, but most of them just like had like a little bit of hypoglycemia, but the rest is fine.
Yes, yeah, macrosomia and hypoglycemia is the most common complication of the GDM. So, do you know the mechanism of it? Why they develop? Why they are at high risk of developing hypoglycemia after birth? Any?
I think because sorry, I keep answering. If
Oh no,
anyone
it's fine. It's
else
fine.
want to participate, I'll give them the chance. But yeah, because they usually like depend on the mother's like nutritional state, and they the mother have like increased insulin, and because they have increased the glucose is rising up, and so when the baby is disconnected, his like their insulin is over the capacity that is needed for the child's body, I think.
Yes, yeah. So in the pregnancy, in the gestation, yeah, you are correct. Mother has high glucose content, which crosses the placenta and to the baby. So baby also get high glucose during the in utero life, and uh, as a response to that, baby's pancreas produce more insulin, right? So this insulin is a anabolic hormone. So it causes macrosomia. So it causes increased cell production, cell growth, right? That's why babies are macrosomic. And then soon after birth, after cutting the once placenta is detached, there is no further glucose supply, but baby is still producing high insulin rate of, yeah, it is producing high rate insulin in a high rate, and then it can cause the hypoglycemia because baby is getting less glucose now only from milk. There is no placental supply, but insulin is producing in high rate still. Then in the first, until baby adapt to the normal glucose rate, in the first 48 to 72 hours, they can have hypoglycemia. So we have to actively screen for hypoglycemia when we have a GDM mother. So other complications are if it is a long-term diabetes mellitus, like chronic diabetes mellitus, baby can have intrauterine growth restriction rather than the macrosomia. And these babies have high risk of having respiratory distress syndrome because it suppresses the surfactant production. And also because of the macrosomia, they are more high risk of having birth trauma and birth asphyxias and high risk of having intrauterine death. Not only hypoglycemia, they can have hypocalcemia and hypomagnesemia, like some electrolyte abnormalities, and also it can affect the heart. Especially they can have hypertrophic cardiomyopathy, but it is transient, especially they get the septal hypertrophy, and rarely they can have the transposition of gate arteries. I'm not sure the mechanism there. And then the left microcolon, that is the diabetes is always affect the microvascular. So it is due to the ischemia to the gut, they can develop microcolon, and uh, some gut atresias as well. Then the polycythemia, due to the hypoxic condition in utero, they produce more red cells and they will end up with having polycythemia and then the jaundice. And rarely they can have this caudal regression syndrome. And then after checking the history, we have to check the baby's growth parameters, right? So birth weight, head circumference, and length. Always not enough to check these things. We have to plot in the centile charts. Here we use WHO charts. I think in your country also you use these kind of centile charts, but this can be vary from country to country. So, but always we have to plot in the charts to identify the variation from the normal range. So if the baby is above the 90th centile of the birth weight, we call they are macrosomic. So the causes are, as I told, gestational diabetes mellitus, or it can be syndromic, or it can be familial. And then they can be low birth weight, like small for gestational age. SGA means small for gestational age. Whenever they are less than 10th centile of the birth weight, we called it small for gestational age. This can be due to placental insufficiency, like diseases like PIH, that is pregnancy-induced hypertension, and any chronic illness of the mother, and malnutrition or congenital infection can cause intrauterine, the small for gestational age, and syndromic babies. And then head circumference, again, you have to check the head circumference and plot in the chart. If it is about 2 centiles above the weight centile, then we called 2 standard deviation from the normal range, we call macrocephaly. And if especially if it is above 98th centile, then we call macrocephaly. And if it is less than 3rd centile, we call microcephaly. And length also important to plot and compare with the other centiles. Then we have to check the general appearance, so activity and the alertness of the baby, and especially the color. You have to check the color. So can somebody tell me what is the normal color and what are the abnormal colors of the babies that you can observe?
I think the best color for the baby is to be pinkish, and sometimes they have like congenital cold feet and hands, but that's normal at first. But if it consisted peripheral cyanosis is okay. But if it is consistent, that's a problem. But if the baby is cyanosed, that means there's like an RDS going, or some type of a problem in the respiratory.
Yes, yeah. So abnormal colors are one thing is as you told Dana, it's baby should be pink, right? And abnormal colors, so pale. So if you have a pale baby, you have to think about 2 things, whether this can be a hemorrhage or this can be a hemolytic disease. So these both condition you have to identify early, otherwise even this can lead to death. So hemorrhage can be due to antepartum hemorrhage, like placental abruption or placenta previa or fetal-maternal transfusion, or if it is a multiple pregnancy, it can be twin to twin transfusion. Donor of the twin can have anemia. And then there is a condition called the subgaleal hemorrhage, that is a serious complication of the delivery, especially the birth trauma, and they can have even intracranial bleeding. And the other category is the hemolytic diseases, as you all know, especially blood group incompatibilities like ABO and RH incompatibility. These days we don't see much RH incompatibility because they offer this ROGAM antibody to the mom, so we don't see it as common as earlier, but still we see ABO incompatibilities and some rare blood group compatibilities. And then sometimes red cell defects can present in the early neonatal life, especially congenital spherocytosis, and rarely these other red cell membrane defects like elliptocytosis and these enzyme defects, pyruvate kinase or G6PD deficiency. So the next color is, as you told, it's a cyanosis. So acrocyanosis, as you explained, it's normal or common in babies, especially due to hypothermia, which we called acrocyanosis in the peripheral cyanosis. But if your baby is centrally cyanosed, that means the mucous membranes or tongue, it can be respiratory or it can be cyanotic heart disease. Or in between, we have a condition called in newborn babies, which is called persistent pulmonary hypertension. That means failure to drop the pulmonary resistance after birth. So pulmonary vasoconstriction is persist and causing hypoxia in the baby. So respiratory, if it is respiratory, you can see severe respiratory distress in the baby, and you can see some abnormal chest X-ray. But in the cyanotic heart disease, maybe they have no respiratory distress, or sometimes they can have minimal respiratory distress because of the hypoxia. And in the X-ray, lung fields are normal, but you can sometimes see abnormal cardiac shapes. And there is no improvement with the oxygen. But if it is a respiratory cause, if you give oxygen and if you give breathing support, they will improve. So when it comes to cyanotic heart disease, you can just remember these 6 T's. First T is for tetralogy of Fallot's and transposition of great arteries, truncus arteriosus, tricuspid atresia, total anomalous pulmonary venous drainage, and then next is the complex cardiac disease. So you don't have to remember these all the things, but if you want, I can share these slides. And then the middle is the persistent pulmonary hypertension. That is also with minimal signs of respiratory distress, but it has disproportionate cyanosis, significant cyanosis of the baby with the normal chest X-ray. But to diagnose this condition, we have to do an echocardiography. And then the next color is the jaundice. I think you all know about the jaundice. So it can be unconjugated or conjugated jaundice, but in the early days of life, they usually have the unconjugated jaundice. It can be due to pathological or physiological causes. Most common is the physiological jaundice. Can somebody tell me why they develop this physiological jaundice? What is the mechanism of developing the jaundice in newborn babies?
Yeah, there are many factors that can contribute to this physiological jaundice. First of all, we are the hemoglobin. So
Yes.
the hemoglobin concentration in newborn is very high,
Yes.
and relative to the adults or children.
Yes.
So it's about 14 to 20. And the immature enzymatic enzymes of the liver that are important for the conversion of the unconjugated to conjugated, and also the enzymes responsible for the excretion of conjugated bilirubin, and also the microbiota inside the gut. There is no microbiota still, so this will lead to increased enterohepatic circulation.
Yeah,
and then the other many causes, yeah, but these
yes.
are the important.
Yes, very good. Yeah, most important cause is the increased breakdown. But yeah, as you described, there are other contributory increase in intrahepatic circulation, immature enzymes. Yeah, very good. And then yeah, if most of the time it is physiological jaundice, but there are other causes also we have to consider, like hemolysis and congenital syndrome, Crigler-Najjar and Gilbert. And when it comes to prolonged jaundice, that is for term babies more than 14 days, and for preterms, if it is lasting more than 21 days, we call prolonged jaundice. And you have to consider about the conjugated jaundice. So it is important to exclude this condition, right? And then the next color is the plethora. So it is due to polycythemia, as you described. Hemoglobin is high in the babies. So sometimes due to some placental insufficiency, hypoxic condition at the birth, they can have high hemoglobin, even higher than the normal, that is more than 220 grams per liter, or hematocrit more than 65. Especially these conditions like IUGR, infant of diabetic mother, recipient of the twin transfusion, and sometimes due to iatrogenic delayed cord clamping. We do delayed cord clamping, but if you do it for a long duration, it can cause polycythemia. Can I ask a question again? You told that babies have a high hemoglobin concentration. Do you know why? What is the mechanism of that? Why they have a high hemoglobin concentration compared to adult or children?
I can guess something, but
yeah,
someone answered. Yeah, he's true. But I was thinking about something which is maybe false. which is the amount of these plasma or serum volume, which is low at the beginning. So I think it's false, yeah.
Yeah, so what is the baby gets nutrition and oxygen from the mother through the umbilical vein, right? So this placental supply is not purely arterial. It has saturation about 70 to 80%. It's not like 90% of saturation in that blood. So baby gets kind of low oxygenated blood from through the umbilical vein, right? As for adaptation to that hypoxic state, baby produce more hemoglobin, and also they have this fetal hemoglobin, which has high affinity for oxygen. So this is the reason that they have high hemoglobin, and then after birth it start destruction, and fetal hemoglobin also has less lifespan, so it started breakdown. So that is a physiological adaptation for the intrauterine life. That's why they have high hemoglobin concentration. Okay, and yeah, then you have to look for any syndromic features. I think you all know about the features of Down syndrome, Edward and Patau syndrome, right? I mean, you can read through this syndrome, but because these are the commonest syndromes that you can see in newborns. So Down syndrome, it's important, just you can read their features, facial features, and other associated features. The importance of identifying these babies in the first few days of life because they can have these structural defects, and we have to intervene early. So commonest congenital heart cardiac problem of the Down syndrome is AVSD, that is atrioventricular septal defects, followed by tetralogy of Fallot's and the ventricular septal defects. Also, they are high risk of having hypothyroidism, so we have to actively screen for them regularly, and they can have some visual problems, they can have hearing problems, and we have to follow up for growth and development assessment. Then Edward and Patavo, you can just, Edward syndrome has these classical features, clenched overlapping fingers, and also rock bottom feet. So these are life-limiting conditions, so it is important to diagnose them early to offer the palliation or help the family. Then we have to go for head-to-toe examination, but I would recommend you to listen to heart before baby start crying. So we have to check the heart rhythm, rate, and murmurs. So just have an idea about the normal rate or normal rates of the respiratory and the heart rate of the babies, because it is not as adults. It's babies have high heart rate, up to 160 in term babies and up to 180 in the preterm babies is normal. Below anything below, if persistent low heart rate around 80 is abnormal for baby, we have to exclude the congenital cardiac block. And even respiratory wise, they have high respiratory rate. They can have up to 60 respiratory rate, it is normal. And you have to look for murmurs. And then head size, as I told, and then the anterior fontanelle and the posterior fontanelle size, because some condition can associated with large anterior fontanelle or the small anterior fontanelle. So there are a list of conditions, you can go through it later, and suture separation or suture, early suture closure of the sutures is also important. Early closure of the sutures we call craniosynostosis. It can be any of these sutures, so you don't have to remember all of these. According to these suture, they have different head shapes, but the important thing is the babies have these separated sutures allow to grow the brain. But if it is early fusion, then the baby's brain growth is it can be arrested. So these babies we have to identify and refer to neurosurgeon for surgery. They can just separate the sutures and then it can improve the brain growth. That is the importance. And then the head masses, you have to check for the any if it is a large mass, it is obvious, but it is small, sometimes it can be missed. Any midline masses can be encephalocele, and this is rare, but the common conditions are this birth trauma. Due to the birth trauma, the baby can have cephalohematoma or caput succedaneum or subgaleal hemorrhage. Caput is the edema of the presenting part, is a very benign condition, disappears within 24 hours. Cephalohematoma is the bleeding under the periosteum, and it is again disappears. You don't have to do anything, but you have to reassure parents. It will take time to resolve. And then subgaleal hemorrhage, it's a serious complication. You have to identify that to prevent babies' ongoing bleeding. We have to support these babies. And then face, you have to check for dysmorphic features, ears, tongue tie. Anything can happen, but some of the condition are benign, especially neonatal teeth. It's a benign condition, but if it is loose, so we have to take them out to prevent the aspiration. And there are some bumps in the gums. These are called retention cysts. These are benign. You don't have to do anything. Preauricular tags is it's not clinically significant, but later you can do plastic surgical referral for the cosmetic reasons. But if there is any sinuses, this can be infected, so we have to refer to ENT. And then this abnormal absence of ears, so again we have to check for hearing and do the ENT referral. Tongue tie, again benign condition, but sometimes if it is going to affect the baby's feeding, you can divide it after referring to the orofacial. And obvious cleft lip palate, you can see them, but especially posterior cleft palate, like this isolated cleft palate, can be missed if you don't check the palate actively. So you have to check the palate actively by using a tongue depressor. And this is called Epstein pearl. This is a benign condition, white patches over the palate. And this is a complication of the forceps, the facial nerve palsy. This is a commonest cause for the facial nerve palsy is the birth trauma assisted delivery. Then you have to look for the eye reflex to the ophthalmoscope to exclude the cataract and retinoblastoma. If there is no red reflex, then it's abnormal. And neck, you have to check actively neck lumps. If it is midline, it can be congenital goiters. And if it is the lateral side, either side of the neck, it can be cystic hygroma or sternocleidomastoid tumors. All these conditions has to be diagnosed early for the intervention. This and the abdomen, you have to check the any abdominal wall defects. This is called gastroschisis, but these are obvious, even antenatally can be identified. But omphalocele, the difference between this thing is omphalocele is covered by this Wharton jelly. It is a herniation of bowel content through the umbilical cord. If it is large, it is easily identified, but sometimes you can see very small ones, difficult to identify. So that's why we have to actually look for it. Those are surgical condition. We have to correct it surgically. And then genitalia, you have to check the genitalia to identify any abnormality, especially ambiguous genitalias. And for boys, there is a condition called this hypospadiasis. So you have to check the urethral opening. If it is not in the tip of the urethra, that is abnormal. That is called hypospadiasis. And then the testis, there should be bilateral testis should be palpable. And clitoromegaly and small penis is associated with ambiguous genitalia. And then you have to turn the baby back side and check any masses to exclude the spinal dysraphism. And it can be this meningomyelocele from cervical areas to lumbosacral. So commonest is the lumbosacral area. these need to be surgically corrected. And if it is sometimes not obvious, you can only see that hair tuft or some small lumps or a sacral dimple. If you can't see the end, these all condition you have to do the refer to the radiologist to do an ultrasound scan to exclude the spinal dystrophism. And rarely you can see these sacrococcygeal teratomas, but it is a large lump which can be identified antenatally. And there are some skin condition, common skin condition like erythema toxicum, which is very common, and this is a benign condition. It is a small white pustule with the papule with the surrounding erythema. So it can be very significant generalized rash, but it is benign. And neonatal acne, again, benign condition. You don't have to do anything. Salmon patches is very common condition. You can see most of the babies, some macular red patches over the eyelids, upper eyelids or nasolabial areas or forehead. That is, if it is happen in this area, glabell area, it is called angel kiss. And if it in the back of the nape of the neck, called stroke bite. This is going to resolve within 1 year, but sometimes the stroke bite is usually persist, but it is little bit fade away. But if you see especially a demarcated macular patch over the face, on the one side of the face, it can be a port wine stain. That is important to identify because it is associated with structural brain defect, and they can develop glaucoma. So it is easy to identify because it has this demarcation, clear demarcation of the lesion. And this is again benign condition, strawberry hemangiomas. It is a raised red patch with a capillary vascular abnormality. This is going to increase in the size over the 1 year and then start regressing. But if it happens over the like eye or mouth, then we have to do the treatment. So dermatologist will give some local application like timolol to shrink it, and sometimes we can use laser therapy. And then congenital dermal melanocytosis, and it's a benign condition, but it's important to document and identify early. And this is especially in some ethnicities, it is prominent, but rarely if it is extensive and if it is in abnormal areas, it can be associated with some rare disorders like lysosomal storage disorders. And cutis aplasia, again, is a kind of benign. You don't have to do anything. It's a skin defect in the scalp, or sometimes it can happen in the trunk, but it will shrink with the time. And then you have to actively look for the talipes. It's a medial deviation of the limb, need early intervention and orthopedic referral to correct this. Otherwise, baby can develop a difficult walking. And hip test, you have to do the Barlow and Ortolani test to identify hip development dysplasia, and early identification and treatment will prevent the morbidity. And finally, you have to check the femoral pulse. And some countries, we check pre-postductal difference to early identify the congenital heart defects. Can somebody tell me what is the pre-ductal and the postductal saturation, and why we have to check this difference? Why there is a difference? Can somebody explain what is pre-ductal and what is postductal?
Yeah. Regarding the autosets, how to measure it? We know the ductus arteriosus. Okay.
Yes. Yeah.
So the preductal is by using the oximeter on the upper limb.
Yes.
Right. For example, the right, which is more accurate. The right hand or finger, one finger of the right hand, and for the postductal, the lower limbs. Yeah. And we see the difference. Okay, it's significant if it's more than 5, and there is a criteria if it persists, we should do an extensive evaluation.
Yes,
So
yeah,
I
good.
don't know if I have answered your question or not. Still anything?
Yes, good. So
Enough?
it's because of the ductus arteriosus. If it is open, you can see the difference if there is a right to left shunt, right? So why we have a difference between the right and left, right limb, right upper arm and the other limbs, it's due to ductus that it opens after the first branch of the 3 branches of the aortic arch, right? You remember that 3 branches we have. So ductus open after the first branch, which supply the right hand and the head. So that's why you don't see the, when there is a right to left shunt through the duct, your right hand get the the oxygenated blood, but rest of the body get the mixed blood. That's why we have differential cyanosis in difference in the oxygenation in the right and the rest of the body. So it is important some duct-dependent cardiac diseases or the PPHN. The PPHN is persistent pulmonary hypertension. So you can see difference because of the duct. If duct close, you can't see any difference of the saturation. And other condition is the coarctation of the aorta. Sometimes if there is a difference in the, because rest of the body, because of the coarctation, rest of the body get blood supply from the ductus, that is the deoxygenated blood, and then you will get the difference in the saturation. So it is important to identify the the coarctation. Sometimes the most important test is the femoral pulse. You have to check the femoral pulse because the coarctation of aorta, it's difficult to identify in antenatal scans. So it can be missed, and then baby can come. It is a treatable condition, and then baby can collapse later if we don't identify them early, right? And I put these two pictures like videos to describe the fetal circulation and postnatal circulation. So is there someone who can describe this fetal circulation? What is the difference between the fetal circulation and then postnatal circulation? Or can I go ahead with?
Yeah, I can
Yeah.
provide an idea.
Okay, so we have this. This is
the placenta, which is the source of oxygenation for the infant.
Yes, so we have placenta in the fetus.
From the mother mainly. It's placenta. So we get the through the veins. So these are in the red are the veins.
This is umbilical vein. It goes to the ductus venous and
so it goes to the right side of the heart.
Yes,
and it should bypass the lungs. Okay.
Yeah.
And through that, it will go throughout the body through by the left side of the heart, left ventricle.
Yeah.
And then go back go back to the placenta again.
Mm-hmm. Yeah, so placenta, through the placenta, most oxygenated blood comes through here to umbilical vein, enter into the IVC, and little bit of deoxygenated blood from the rest of the body comes here, and both combined. But this is the most the oxygenated blood directed to the right atrium through the foramen ovale to the left atrium, right? So left atrium to left ventricle, and it goes to the aorta to the rest of the body. So the oxygenated blood goes to the head and the body, and then little bit of blood goes back to the through the IVC, and rest of the blood to the placenta. And here from the SVC, the head and neck area, blood come through the SVC directed to the right ventricle, and from the right ventricle to the pulmonary artery, but only very minimal of blood goes to the lungs because baby is not breathing, fetus is not breathing, so lungs is in the collapse state, and then this blood directed to the aorta again through the ductus arteriosus. So that is the fetal circulation. So fetus has the ductus arteriosus and the foramen ovale open to maintain this circulation. But after birth, what happened? Baby start breathing, first breath, and pulmonary circulation increase, and lungs open. So the left side pressure increases, and then foramen ovale functionally close, and blood's the ductus also functionally close, and then blood coming. There is no placental circulation now. Placenta is cut, so baby has to maintain his circulation. So blood from the right side goes to the lungs. Now lungs open and it comes to the left ventricle and to go to the aorta. So that is the difference between the fetal and the postnatal circulation, right? So main differences are there is no placental circulation. Baby now breathes, and then the lungs are expanded. Blood has a two parallel circulation, left and right. There is no mixing in the normal situation, right? All right. Do I have time to go through the resuscitation a little bit?
I personally don't mind. I don't know about others.
Okay. Then we will continue. So can someone tell me what is the important thing of the if you have a collapsed baby, what is the difference between a collapsed baby and collapsed adult? How do you approach them? What is the difference? What do you think if you see a adult collapsed adult, what do you do? How do you approach that one? What is your main diagnosis there? Is it a cardiac arrest or a respiratory arrest?
Mostly it's cardiac.
Yeah.
And I will approach it by the ABCDE approach mainly.
Yeah.
Or the ABC approach, which is sometimes called it's ABC.
Yeah, always it is for anyone ABCD approach, but if you see a collapsed adult, we know that it is a cardiac arrest, right? It is not usually a respiratory arrest. But if you see a collapsed baby, that is 99% of the time it's a respiratory arrest. So that is the difference. So you have to give the respiratory support rather than the cardiac support. And then if you give the respiratory support, then the baby's heart will improve. So that is the difference in neonatal resuscitation. So we have to consider some
Doctor,
factors.
excuse me.
Yes.
Can you do something important now by differentiating for us two terms? So when we say or hear neonatal resuscitation, I go my thinking goes to the resuscitation after delivery. So it's the same term, neonatal resuscitation. And now we are talking about neonatal resuscitation, like the pediatric cardiac life support. So these two terms, are there better terms to describe them? One of them to differentiate the other, or using the same term for both conditions is appropriate? What's your perspective about this point, please?
Yeah, I mean a newborn resuscitation at delivery suite, and you mean the approach. It's like same because most of the time it's a respiratory arrest for the babies and even children. If it is not a cardiac condition, then it's always respiratory arrest. So is that the question you're asking? It's approach.
Yeah. As a student, I know that as a specialist or resident, you can differentiate this. But as a student, I just get missed these two terms. The resuscitation, which is drying and warming the infant after delivery, the baby newborn after delivery, it's called resuscitation. And the resuscitation when there is no breathing, which is we will use the pediatric cardiac life support. It's called also resuscitation for newborn or neonate.
Yeah. I mean, that is two different things actually. The approach is different because for the newborn resuscitation, it's a different approach. It's always ABCDE, but the newborn has these different things. Like they are very small, they are with lungs full of fluid. The pathology is different. But for the children's collapse, the pathology is that is different. So you have to, even though the approach is same, the pathology is different. So you have to, when you have a child resuscitation, then you have to identify the underlying pathology. You have to give all the same things, but the pathology is different. So I think if it comes to resuscitation, it's two different scenarios. Did I answer your question? Or?
Yeah, thanks so much, doctor.
Okay, so yeah, for neonatal resuscitation, it can be the mostly delivery suite collapse or sometimes postnatal collapse. But for those babies, mainly the same approach we do, especially it is cardiac arrest, unless there is a significant cardiac problem like duct-dependent circulation, as I told, like coarctation of aorta. But still, our approach is the respiratory first. So, especially delivery suite collapse, we have to consider the pathology. They are small and wet, and their lung is full of fluid. So, we have to inflate the lungs, right? So, neonatal resuscitation, the physiology behind that is pathology, and physiology behind that is lung. We have to aerate the lung, which has a lot of fluid, right? So babies at birth are prone to hypothermia. We have to keep it in mind, and hypothermia can worsen the condition. And they have unexpanded lungs from birth because it's full of fluid. If baby doesn't start crying, still lungs are very collapsed, not expanded. So we have to think about that. And they take times to reach the oxygen saturation. And also they have a capacity, not like adult, they have a capacity of these gasping breaths to maintain their saturation. And also their cardiac glycogen stores are high, so they can maintain the cardiac metabolism even if in the hypoxic states to certain uh, duration. And as we all know, baby have this stimuli for the first breath with the cord obstruction, temperature change, and the physical stimulation. Baby start crying. Crying means the first breath, and then a lot of the lung fluid absorbed within second, right? First breath means baby create a negative pressure inside the thoracic cavity and pull the air inside and then push the fluid away from the airway and alveoli and establish the resting lung volume. This lung fluid absorbs into the lymphatics within seconds. If you take X-ray, just after birth, you see only the very wet lungs, white lungs, and then with seconds you can see nice aeration. This is the normal adaptation of the baby. But if baby can't cry, then if there is no breathing, babies end up with having this much of fluid in the lungs. So we have to actively expand the lungs. That's why we have to give this inflation beds in our neonatal resuscitation, right? So this is the pathophysiology behind the neonatal collapse, especially the uh, at birth. So if there is any oxygen failure in the utero due to placental problem, baby's oxygen falls down, and because of that, baby start breathing. But inside the utero, even if baby breathes, there is no oxygen supply to the baby. So baby stop breathing. So respiratory center stop stimulation and stop breathing, and then he's going to the primary apnea phase. And then after some time, spinal center stimulate and baby start gasping breathing. That is the second stage. And then still, if baby sit inside the utero, there is no effective breathing. Baby can't take the oxygen, and then baby stop breathing again, which is called terminal apnea. If we identify baby here and deliver here, baby will recover soon because baby's oxygen has fallen down, but baby maintained the CO2 and the heart rate and the blood pressure. So with the stimulation or with the minimal support, baby start crying. But if we baby go to this secondary or terminal apnea, now baby's heart rate has dropped down, blood pressure has dropped down, CO2 has accumulated, and baby has gone to anaerobic metabolism, so excess acid accumulate. So this will cause, if we don't intervene here, at least here, baby will die. But if baby delivers here, and if we can start the resuscitation here with the lung aeration, then with the significant respiratory and the cardiac support, baby can survive. Right, so we use this algorithm for newborn support here in UK, but this can be varies from countries to country, but the pathophysiology is the same. So you have to inflate the lung. So our assessment is color tone breathing heart, CTBH, and again dry and cover airway breathing circulation, drugs, environment, and the family. So there are some anatomical variations of the baby when we have to consider while we are resuscitating a baby. The most important thing is the airway anatomy. They have high anterior larynx and they have a horseshoe-shaped epiglottis, and their soft tissues are very compressible and they have large tongue. So when you have a collapsed baby, we have to keep the baby in the neutral position to avoid airway collapse. If your baby is flexed position, it can obstruct the airway. Even the extension position can obstruct the airway because it is very anterior. So always we have to keep the baby in the neutral position, dry, and first you have to dry the baby, keep the neutral position, and then assess with the CTBH. And then you can start inflation breaths, which we called, anyone knows about the difference between this, why we call this inflation breaths? Have you done your NLS or any experience in newborn resuscitation? Do you have any experience? So I'm not sure which algorithm you use in your countries. Inflation breaths is the difference between this inflation beds is, as I told you, baby has a lot of lung fluid. We have to give some pressure, sustained pressure to push out the lung fluid. So we have to give about 30 centimeter of water pressure for a 3 seconds to push out the these lung fluids. So we give 5 inflation breaths, long, high pressure breaths. And then if we can't open up the lung, if you can't see the chest rise, that can be due to the airway problem. So we can use these airway adjuvant to open up the airway, oropharyngeal airways or supraglottic airways, which we called iGel, or this is called iGel. We can use LMA or iGel to open up the airway. And we can consider jaw thrust, that is a 2% technique. And then we have to select all these appropriate size and give some breaths. So to give breaths, we can use this bag and mask, or these days we have this NeoPuff machine. Then we can use either with the availability, the facility. And so 5 inflation breaths, if you can't get the chest rise, then we have to still go for the inflation breaths, because in babies, we know that the cause is the respiratory problem. So rather than going for the chest compression, until we get the proper chest rise, we have to inflate the lung. So we usually continue the inflation breaths until we get the proper chest rise, and then continue with the ventilation and reassess the baby. If it is not improved, then we go for the cardiac compression. And cardiac compression, after 1 cycle of cardiac compression, if it is still not improved, so always we have to reassess every 30 seconds with the CTBH approach, that is color, tone, breathing, and heart rate. And if it is after chest compression, if it is still not improved, we go for adrenaline, and this can be continued every 30 seconds. Every 30 seconds we have to reassess, and every other cycle we give adrenaline. So if we can give maximum support, optimal resuscitation for 10 minutes, and if baby is not improving, then we have to consider about stopping the active resuscitation, because babies can have significant brain damage with the hypoxia. So if your baby is improved, then you have to think about the post-resuscitation, continuous breathing support, maintain normal circulation, temperature, normal glucose, electrolytes, and then we have to think about this hypoxic ischemic encephalopathy. That is the most serious complication that they can have after hypoxic event. So nowadays, after these TOBI trial and cooling trials, we offer cooling therapeutic hypothermia for babies after post-resuscitation to minimize the brain damage. So we have different criteria for that. We assess the pH, cold gases, and ABGAS score, and neurological assessment, and then the brain function activity. According to these criteria, we start cooling. So yeah, I think that is it. If you have any question, I rush through these slides because I think it's a time also passed. I don't know whether you have to leave. So if you have any question, just I can answer. And thank you for listening.